Have you ever imagined your kidneys, those small fist-sized filters, quietly working day and night, suddenly turning into balloons? Tiny sacs of fluid start to grow inside them, hundreds of them, slowly crowding out the healthy tissue. That, in simple terms, is polycystic kidney disease. In this session, we're going to dive into the story of PKD, why it happens, how it shows itself, the dangerous surprises it carries beyond the kidneys, and the new treatments that are changing lives. So let's get started. Polycystic kidney disease is inherited. It's not something you catch, it's something written into your DNA. There are two main types. The common one is autosomal dominant PKD, often called ADPKD. It usually shows up in adulthood, and if a parent has it, each child has a 50% chance of inheriting it. About 1 in every 500 to 1,000 people worldwide carry this legacy. The rarer form is autosomal recessive PKD, or ARPKD, which is far more severe. This one strikes babies and children, sometimes even before birth, and can be life-threatening. Now, why do these cysts form in the first place? Inside every kidney tubule is a tiny structure called a primary cilium. Think of it like an antenna, sensing flow and keeping growth under control. In PKD, mutations in genes like PKD1, PKD2, or PKHD1 damage these antennae. The cells lose their sense of direction, signaling goes haywire, and they start producing fluid and multiplying abnormally. The result? Small outpouchings that turn into cysts. These cysts eventually detach and grow independently, like rebellious teenagers ignoring the rules of the nephron. Over decades, they expand, compress blood vessels, cause scarring, and destroy normal kidney tissue. So how does this play out in real patients? The earliest and most consistent sign is high blood pressure. That's often how doctors first stumble upon PKD, especially in young adults. Patients may also complain of flank pain or a sense of abdominal fullness. Blood in the urine is common, caused by cysts rupturing. Recurrent urinary tract infections, kidney stones, and gradual decline in kidney function are also part of the picture. And when you examine them, the kidneys may be so enlarged and irregular that you can actually feel them. In recessive PKD, the story is even harsher. Newborns may be born with massively enlarged kidneys, making their abdomen look distended. They can struggle to breathe because the enlarged kidneys crowd the lungs, leading to pulmonary hypoplasia. If they survive infancy, they may go on to develop liver problems from congenital hepatic fibrosis. But PKD isn't just about the kidneys. It's a systemic disease. Many patients develop liver cysts, especially women. Some carry silent but deadly brain aneurysms, small balloon-like dilatations in blood vessels that can rupture and cause sudden death. Heart valve problems, colonic diverticula, abdominal hernias, and even pancreatic cysts can occur. So, when you're evaluating a patient with PKD, you always have to think beyond the kidneys. Diagnosing PKD is often straightforward. Ultrasound is usually the first test, and it can show multiple cysts in both kidneys. In younger patients, the number of cysts needed to make the diagnosis depends on their age, especially if there's a family history. CT or MRI can be used when more detail is needed, and MRI has the advantage of calculating the total kidney volume, which is actually a predictor of how fast the disease will progress. Genetic testing can help confirm the diagnosis, particularly in atypical cases or when families are planning children. Now let's talk about management. The unfortunate truth is that we don't yet have a cure for PKD. What we do have are strategies to slow it down and manage the complications. The single most important thing is controlling blood pressure, and ACE inhibitors, or ARBs, are usually the first choice. A newer drug called tolvaptan, which blocks vasopressin receptors, has been shown to slow the growth of cysts and protect kidney function. But it comes with challenges like liver toxicity and frequent urination, so patients need careful monitoring. Infections of the cysts need antibiotics that can actually penetrate into the cyst fluid, such as fluoroquinolones. Pain needs to be managed carefully, sometimes requiring cyst drainage. And when the kidneys eventually fail, patients move on to dialysis, or, ideally, a kidney transplant. Interestingly, transplanted kidneys do not develop cysts, which is a huge relief for patients. One of the big debates in PKD care is whether everyone should be screened for brain aneurysms or just those with a family history or neurological symptoms. Different guidelines take different stances, and this is still an area of active discussion. So what about prognosis? For autosomal dominant PKD, severity depends on which gene is mutated. PKD1 mutations are more aggressive, leading to kidney failure around the 50s, while PKD2 tends to be milder, with many patients keeping kidney function into their 60s or 70s. Autosomal recessive PKD, on the other hand, is often life-threatening in infancy, but survival rates are improving with modern neonatal care. The future looks promising. Researchers are investigating mTOR inhibitors, somatostatin analogs, and even gene therapy approaches. The hope is that we'll move from slowing the disease to actually halting or reversing it. So, to wrap up, polycystic kidney disease is the story of kidneys turned into balloon factories, of families carrying genetic time bombs, and of medicine racing to stay one step ahead. It's a reminder to us as future doctors that every patient is more than their kidneys. You need to think systemically, you need to think genetically, and you need to think long-term.